This article is looking at the prevalence of neurological lesions after total shoulder arthroplasty, from a single centre in Geneva that was published in the JBJS of this month. So just a bit of background. There is evidence throughout the literature of nerve injury post-total shoulder arthroplasty, which can be from a range of different causes, such as direct damage, hematomas, or and even interscalene blocks. However, there's been a question about an even higher prevalence of nerve complications post-reverse total shoulder arthroplasty, and this is thought to be because of the requirement for an alteration in the positioning and therefore the lengthening of the arm. Lengthening in terms of nerve injury is thought to have a direct impact on the blood flow within a nerve, and it's thought that in the sciatic nerve over 8% can lead to this effect, but the level in the upper limb hasn't really been completely determined. The aim of this prospective study was to assess the prevalence of nerve injury during reverse shoulder arthroplasty compared to anatomic shoulder arthroplasty. And the way in which they analysed this was by assessing consecutive patients presenting for shoulder arthroplasty from 2007 to 2009. All the procedures were performed by a single surgeon, and each had some similar post-operative management. They excluded patients who had incomplete documentation, follow-up less than 10 months, and comorbidities that would increase their risk of a neuropathy. In addition, they excluded patients that would have abnormal influence on the measurements of arm length post-operative. They went through a series of baseline characteristics for all the patients, and every patient that was included had an EMG study done 1 week preoperatively and then at the 3 weeks post-operative stage. Each EMG was done by a blinded doctor, a doctor that was blinded to the procedure that had been done, and they also had every patient had a series of x-rays to help in assessing the length difference. Patients were followed up for up to 18 months to assess for persistent symptoms, and a separate orthopaedic surgeon assessed the medical records for each of the patients. The outcomes that were collected were EMG confirmed neurological lesions and also the clinical examination abnormalities. The prevalence of the neurological lesions were then compared to arm length pre and post-operatively and pre-existing neurological lesions. The EMG, as I said, was done 1 week pre-operatively and 3 to 4 weeks post-op by these blinded physicians, and they had a protocol for exactly what they were measuring, which was the motor and sensory assessment, and the nerve conduction velocity, and also a detection for abnormal nerve conduction, which is represented by positive sharp waves, fibrillations, and complex repetitive discharges, as well as fasciculations. After collecting the final population that was included in the study were 34 patients that had a reverse total shoulder and 43 that had an anatomic shoulder. They were the population that could have been included, but the actual final included numbers were 18 patients in the reverse group and 23 in the anatomical group. One of the patients in the reverse group had bilateral shoulders done. Each patient was followed up for an average of 12.2 months. This is a table just comparing the different baseline characteristics. So overall, the majority were female. They had similar age groups, and majority, again, were dominant arm. and just going through a bit more of the detail, they had preoperative constant scores, which I'll go through, that were similar at baseline as well. Some differences were that the reverse group had a slightly increased age range and a higher rate of secondary osteoarthritis as their indication for the operation. Otherwise, the preoperative prevalence of neurological injuries was similar between the two groups. The indications for the reverse total shoulder majority were in rotator cuff arthropathy, otherwise post-traumatic arthritis, and one patient was for a chronic dislocation. The indications for the anatomical shoulders was primary osteoarthritis and post-traumatic arthritis. This table is just going through some of the outcomes that they had from this. So the first column is looking at the number of patients that had a reverse shoulder, so 19, and those that had an anatomical shoulder, so 23. Of those, the patients that developed an acute post-operative lesion, so EMG showed an abnormality post-operatively, this was seen in 9 of the 19 reverse shoulder patients, and only 1 of the anatomical shoulder patients. Worsening of a pre-existing neurological injury was seen in 3 of the reverse shoulder patients, but none of the anatomical patients. Of those that had post-operative neurological abnormalities, the 9 in the reverse shoulder group, 8 out of 9 had resolved by 6 months follow-up. And of the 3 in the reverse shoulder group that had a worsening of a pre-existing symptom, 2 were from carpal tunnel and 1 was from cubital tunnel syndrome. The one that was seen in the anatomical shoulder group was an axillary vein injury and an intraoperative injury that resulted in a brachial plexus lesion with incomplete recovery at the 12-month stage. So to summarise that, acute post-operative nerve injury was seen to be significantly higher in the reverse shoulder group compared to the anatomical group, with a relative risk of 10.9, so which was statistically significant. There was no evidence of other precipitating causes or associated causes for this raised effect, and it wasn't related either to the presence of previous surgery, as no patients who had previously had an operation had any neurological defect. The average lengthening for these groups, so in total, the reverse total shoulder group had an average of 2.7 centimetres lengthening compared to their other side. So lengthening, just as a background, it was only measured in the reverse total shoulder group, and they then divided it into the groups who didn't have a pre-existing nerve injury and those that did. So of those that had no pre-existing nerve injury and then subsequently had a post-operative EMG change, they had an average of 4.2 centimetres of lengthening, while the group that had no EMG change, so a normal EMG, had only 2.6 centimetres of lengthening. In contrast, the group with a pre-existing nerve injury had subclinical change in, and subsequently the group that had subclinical EMG changes had a lengthening of 1.9 centimetres, but this was less than those with no EMG changes in this group with pre-existing nerve injury. So the study then went on to compare the shoulders that had no preoperative neurological injury to those that did have a pre-existing lesion. So of those patients, this is starting to get a little bit complicated, but I'm not entirely clear why they divided it in this way, which made it hard to assess in the paper and to actually get the numbers out. But basically, they divided those, so the group that had no preoperative neurological injury had those that had a reverse total shoulder, 2 of them had a postoperative lesion, and none of those in the anatomical group had a postoperative lesion. Of those that had a pre-existing lesion present, so 9 in the reverse shoulder group, 7 developed a postoperative lesion, but only 1 in the anatomical. The constant Murley score, which is a patient-reported outcome looking at a range of different aspects such as pain and strength, there was a similar improvement in both groups, in both the reverse and total shoulder group. So there wasn't, and this was seen to be statistically different from the preoperative measure. The only statistical analysis they really went through was the confidence interval assessment and post-trial power calculation, which they, based on their numbers, said that they had a power of 92%, although they contradicted this a bit later by saying that they needed much larger numbers in the study in order to get a decent power, or power of greater than 80%. So to summarise, the strengths of the study were that it was prospective. They did have blinding of the assessors. They did calculate power, although it was retrospective, and there was consistency in the recruitment and the operation being done by one surgeon. And using EMG makes it more reproducible than a clinical measure. However, as I said, they did only retrospectively calculate their power, which meant that overall the study was underpowered. They had, therefore, a very small number of patients, and only 1 surgeon was included. It was a single centre study, and I guess some of the information wasn't really included, such as lengthening in the anatomical shoulder, or whether there were other. They didn't really present all of their data in comparison to other studies. So a retrospective review of 39 different studies within a recent JBJS current concepts review, where they looked at a total of over almost 3,000 total shoulder replacements, and had an outcome of about 0.7% of neural events from total shoulder replacements, although it didn't really divide into the different types. An article from 2007 looking at hemi and total shoulder arthroplasty had showed 56% of patients having nerve dysfunction during intraoperative monitoring, and only 7 of the 17 patients had persistent postoperative abnormalities. And lastly, a study on reverse shoulder arthroplasty showed a 4% postoperative neurological abnormality, although this was all clinical evaluation and not EMG. So in conclusion, there is a subclinical, thought to be a subclinical increase in the risk of neurological injury post-reverse total shoulder replacement compared to anatomical shoulder replacement. The majority of cases from this study were shown to have resolution of the abnormality, and the increased risk may be due to arm lengthening, but further studies are needed to determine the actual threshold for lengthening and to